Shall we go ahead?
Sir,
Yes.
Yes, please.
Yes, sir.
Good evening, ladies and gentlemen. A very, very warm welcome to Secrets of Neurology, a knowledge field for all the neurologists. But before we get started, let me wish all of you a very, very happy and prosperous New Year 2022. This is one of the longest web series in academia. This is episode 18th. A warm welcome to our course director, Dr. Sudhir Shah, and Dr. Lakshmi Narasimhan, and also a very, very warm welcome to the faculty of Sri Ramakrishna Institute of Higher Education. We intend to close this program before 10 o'clock. It's my honor and privilege to briefly introduce somebody whose introduction is very difficult because he's such magnanimous, Professor Dr. Sudhir Shah, Professor and Head of Department, NHL MMC and SBPI MSR, Ahmedabad. Professor Shah is also Director of Neuroscience at Sterling Hospital, Ahmedabad, author of 6 book chapters in neurology. Because of his excellent work in the field of neurology, community and patients at large, he has also been conferred with prestigious Padam Shri. He is also recipient of prestigious PC Roy Award and recipient of Yona Award. Our second program director is equally in the same steam, Professor Dr. Lakshmi Narasimhan.
Before 1 minute, Manoj, I want to share the happy news of are you going to announce that the sir has got the Royal College of Physicians Award FRCP and is being honored by the Royal College of Physicians of London? I think all of you will give a big hand for that. I thought it's a very happy moment to share that with all of you, and it's one of the along with the highest awards in the country like Padma Shri and PC Roy. Sir, fame has shot up to UK and is being given the prestigious Fellow of Royal College of Physicians UK. And we are all very extremely happy, sir. We are blessed to have you amidst us. Thank you, sir.
Truly, we are all blessed, sir, and many, many congratulations once again for this coveted, prestigious award.
Congratulations, sir.
Thank you very much, everybody.
Congratulations, sir. Congratulations.
Congratulations.
Is there grace from above and good wishes from all of you? Thank you very much. I am in fact happy, honored, and humbled. Thank you very much.
My honor and privilege to also welcome Professor Dr. Lakshmi Narasimhan, Director and Professor, Institute of Neurology at prestigious Madras Medical College, Chennai. Sir has been having many awards and accolades to his credit. Paltussi, A.V. Baker's Award for Global Best Teacher, Best Paper Award, excellent contribution to the field of neurology at a global platform and in the Indian setting. Both the program directors have been working extremely hard to make this web series the longest web series to all of us. Thank you, sir, for your contribution, and may I request both our program directors to take it forward from here.
Friends, once again, we welcome you all for this wonderful web series, Secrets of Neurology, Knowledge Feast for All Neurologists. As you know, this is the 18th episode, and I must, at the outset, congratulate and thank INTAS for this untiring endeavor and their enormous logistics support. I must also thank my co-convener, course director, Dr. Lakshmi Narasimhan. As you know, a very profound man filled with a lot of knowledge and still humble, kind, and always smiling and helping. I must acknowledge that without his help, I could not have really ventured this long web series. And we wish to continue for at least another 6-12 months, depending on the response. And therefore, I must thank all the participants and delegates for their continuous patronage and their participation. I must also thank all the different medical colleges and the students, their assistant professors, associate professors, and professors for sharing their knowledge, presenting cases, and dissecting out the localization and etiology and enriching us with all great knowledge. This time we have two intriguing cases with X and breaks from the team of Sri Ramachandra Institute of Higher Education and Research, Chennai. Our friend Professor Shankar was supposed to head the team this time, but because of some medical emergency in his family, probably he has been replaced at a very short notice by Professor Sundaram. We must thank Professor Sundaram for his kind acceptance. The first case, I think, will be presented by Dr. Uma Ravishankar. She is a resident in neurology at Sri Ramachandra Institute of Higher Education Research. This will be discussed, next slide, by Dr. Radhakrishnan Perapatti. He is an assistant professor at the same institute, and he has been awarded with Manohar Lal Soni Book Prize for Haji and Abdul Kader Ibrahim Memorial Gold and from JIPMER. He is also membership of Indian Stroke Association, IAN and IES, and he has several research publications and papers, and he has participated in various national and international conferences. Next slide. The second case will be presented by another resident of neurology, and that is Dr. Savya Inumpudi. Next slide, please. And that would be discussed and dissected by Dr. Ritvik Ramesh, another assistant professor from the same Ramachandra Institute of Higher Education and Research. Dr. Ritvik Ramesh has been awarded with MG Ramachandra Gold Medal in medicine, and he has been also member of IAN, AAN, and EAN. He has also good number of publications in various national and international journals, 4 book chapters, and oral and poster presentations, and he has dissertation paper on prevalence of insulin resistance in treatment of naive hypertension and clinical radiological characteristics, subgroup analysis and outcomes of autoimmune encephalitis in tertiary care center. Next slide, please. As has been mentioned by me, Dr. Sundar has been very kind to have accepted on both these short notice. Same institute, although he's an alumni from Madras Medical College. And 2012, sports and continuing epilepsy by AN, life member of the Indian Medical Association. Again, he has 16 publications, 11 presentations, and presentations. So, I invite Dr. Lakshmi.
Yes, sir. Yes, sir. And I also, my sincere thanks to Professor Sundar for accepting to discuss the case in such a short notice. And over to Dr. Sundar for further proceedings. You can request the president to start.
Thank you, sir. Good evening, everyone. At the outset, I would like to convey my sincere apologies on behalf of our HOD, Professor Shankar sir, as sir is held up in emergency. And next, I would like to thank our course directors, Professor Sudhisha, Professor Lakshmi Narasimhan sir, for giving us this opportunity to present in this forum. And today we have 2 nice cases from our department under the topic aches and breaks. The first case, as told, will be presented by Dr. Uma Shankar, our senior resident, which will be discussed by our AP, Dr. Radhakrishna. The second case will be presented by Dr. Shavya, and which will be discussed by our assistant professor, Dr. Ritvik. Hope these two cases will be interesting to all of you, and over to Dr. Uma.
Yes, sir. So good evening, everybody. So I'll start with the first case. So this is the case of a 23-year-old male who's an engineering graduate who presented to us with history of pain and tightness in the back for the last 2.5 years, gait difficulty with tightness and pain in lower limbs for 2 years, and thinning of muscles of both hands with paresthesias in both hands for 3 months. So patient was asymptomatic 2.5 years ago when he noticed insidious onset, gradually progressive, dull aching pain in the lower back, which was occasionally cramping, which gradually spread to involve the upper back and proximal bilateral lower limbs over the next 6 months. Initially, the pain was present only on exertion, but subsequently became continuous. It was aggravated by exertion and partly relieved with rest in supine position and was not aggravated with pressure on the back or legs. Occasionally, he had spontaneous exacerbation of pain lasting up to minutes to hours, associated with increasing tightness of the muscles. He had no other aggravating or relieving factors for this pain. There was no radiation of pain. There was no diurnal variation of this pain. Initially, the pain was around 3 to 4 on the visual analog scale, but at the time of presentation, it was around 6 to 8. It was disabling, but it did not disturb his sleep. The second complaint that he had was tightness, initially involving the lower back, but which was again insidious in onset, gradually progressive, which over the next 6 months subsequently progressed to involve the upper back and proximal bilateral lower limb. It was an insidious onset, gradually progressive pain with occasional spontaneous worsening with the tightness for up to minutes to hours, and it subsequently returned to baseline on its own. Initially, the patient noticed that he had difficulty in bending to pick up things on the floor. For the next 2 years, he noticed that he had difficulty in walking, that he would walk with short, slow steps, and he always had the fear of falling down. His thighs felt tight and it did not allow free movement, particularly at the knee. He also had difficulty in squatting and climbing stairs, predominantly because of this tightness. But whether he had coexisting weakness, we could not tell from this history. Gradually, his other activities were affected in the sense that he had difficulty in sitting supine from bed, and this was a debilitating progressive weakness to the point that over the last 3 months, he was bedridden for the most part of the day, and he was able to ambulate to the washroom, that too only with support. At this stage, he presented to us at our hospital. He had no difficulty in wearing slippers and walking with them. He had no history of tripping over objects or dragging of feet. There was no history of involuntary movements, thinning of muscles in the lower limbs, muscle twitching, or flexor spasms. There was no swaying, sensory disturbance in the legs apart from pain, no bowel or bladder abnormalities. The third symptom he noticed was that there was thinning of both hands for 3 months, which again was insidious in onset and gradually progressive. He also noticed paresthesias in the medial aspect of both hands, particularly on waking up after sleeping when he slept with arms bent at the elbow. He had mild difficulty in buttoning and unbuttoning his shirt for the last 3 months, but he was able to do it on his own. However, he had no difficulty in holding and lifting objects overhead or taking food to his mouth. There was no history of numbness or twitching of muscles. There was no thinning of muscles or paresthesias anywhere else. There was no history suggestive of any cranial nerve, cognitive, or cerebellar involvement. 2 years ago, he was treated for depression with psychosis and he recovered completely. There was no history of joint pain, mouth ulcers, rash, fever, weight loss, dryness of eyes or mouth, or any history of chronic cough. He had no previous chronic illness, no history of diabetes or hypertension. There was no history of addictions. He had consumed a mixed diet. He had a normal sleep. and normal appetite. There was no history of significant neurological disease in the family. He was born to a non-consanguineous marriage, and he had an elder sister who also did not suffer from any disease. His treatment history: he was previously treated with trihexyphenidyl and tolperisone and multiple analgesics, which he discontinued after 1 year because he had no improvement. He also tried a course of alternate medicine but found no relief. So, summarizing the history, this is a history of a 23-year-old male who presented with insidious onset, gradually progressive, painful stiff back for 2.5 years and lower limbs for 2 years, leading to ambulatory difficulty with bilateral element type of hand weakness with paresthesias for 3 months without bowel, bladder, cognitive, cranial nerve, cerebellar, and other sensory symptoms with a negative family history. Any comments at this point?
If there are none, I think you can go for Dr.
Yes. So, symptom
One comment someone has. Okay, symptom analysis we are going to do.
So, analyzing his symptoms. So, this was our thought process at that point of time. So, with the history of pain that he gave, we thought of could it be localized to the muscle. So, the points in favor was that it localized to specific areas of muscle stiffness with worsening of pain, with tightness and occasional spasm. So, this went in favor of a localization to the muscle. The second DD we thought of was whether any bony or ligamentous tissues of the spine. So he did have a dull aching pain which worsened on exertion, but his young age pointed against this diagnosis of any degenerative disease. The third localization was to the spinal cord, as he had muscle stiffness and gait difficulty, but the pain was not funicular and it was well localized. We also considered a radicular etiology, as the pain involved the lower back, and lower back involvement is a common site for radicular pain. But there was no history of any radiation of pain or pain which aggravated on coughing, sneezing, or any increased pressure. And lastly, we also considered peripheral nerve hyperexcitability syndromes, which could cause spasms and stiffness, but there was no history of myokymia. So the next symptom that he had was muscle stiffness. So the first, again here, we thought could it localize to the cord, as he had muscle stiffness with gait difficulty. But the fact that he did not have any bladder or bowel involvement went against this diagnosis. Second, could he have any basal ganglia involvement because he felt it was a predominant stiffness? Then again, the point that went against it was a pain was his predominant symptom. He did not have any history of bradykinesia and there was no history of tremor. Again, could it localize to the nerve? Muscle stiffness with superimposed spasm, could it be a symptom of hyperexcitability? But as he had no twitching or myokymia, we decided against this. The third symptom that he mentioned was paresthesia and hand wasting. So first, could it localize to the ulnar nerve? Because this paresthesia was predominantly on flexing the elbow, but it did not correlate to muscle tightness anywhere else. Second, could it localize to the medial cord or lower trunk? He had hand weakness with paresthesia, but bilateral involvement of the plexus seemed unlikely. Again, could it involve the radical? He did have hand weakness and paresthesia, but the pain was not radiating in character. And the point against a cord localization was, again, there was no bowel or bladder involvement. So our final localization, we localized the muscle spasms and pain and stiffness to the spinal cord. And the hand wasting we thought was unrelated to the primary disease, probably due to a compressive ulnar neuropathy at the elbow due to immobility and posture. So the differential diagnosis that we considered at this point was could it be stiff person syndrome, as he presented with pain and stiffness with early inability to bend with superimposed spasm, but the bilateral hand wasting did not go in favor of this diagnosis. Could it be hereditary spastic paraparesis? It was an insidious onset, gradually progressive symmetrical limb stiffness But the predominant symptom was pain, which again with early inability in movement. So this again went against the diagnosis. Third, given his young age, we considered ankylosing spondylitis with superadded myelopathy, as he did have inability to bend and pain in the back, and he did have a young age of onset. But the severe stiffness in the lower limb without any sensory or bladder symptoms and no diurnal variation, no predominant improvement with exercise, all these points went against this diagnosis. Again, peripheral nerve hyperexcitability was considered, but there was no history of myokymia or fasciculation. And given cervical spondylosis or spondylotic myelopathy with lumbar spondylosis being a common DD, we considered this also. But his age and lack of bowel bladder or sensory symptoms went against this diagnosis. We also thought of rarer causes, other metabolic, autoimmune, infectious, and paraneoplastic myelopathies. But his early inability to bend and lack of bowel or sensory symptoms went against this. So then he proceeded to examination. So on examination, he was conscious oriented, vitals were stable. There was no pallor icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema. He had dark hyperpigmentation of both feet. There was wasting of bilateral hypothenar eminence and introitiae. There was a pressure sore in the right foot, and examination of other systems was normal. Neurological exam revealed normal higher mental function, normal cranial nerve examination. Examination of motor system revealed wasting of small muscles in both upper limb, predominantly in the hypothenar eminence and introitiae, sparing the thenar eminence. There was no fasciculation, myokymia, or any other muscular involuntary contractions. He had severe axial rigidity, which was of lead pipe type. Upper limb rigidity was lesser compared to lower limb and back muscles, and the range of motion was limited due to painful rigidity in the lower limb. Upper limb power was 5/5, except for weakness in the ulnar innervated muscles in the upper limb. And lower limb, the power examination was suboptimal because he could not bend his knee joint, predominantly the knee joint, because of severe stiffness. So what he could do, the hip muscles was around 2/5. Knee, he had severe difficulty in bending it by himself, but with effort, we were able to bend his knee. Ankle power was around 4/5. Superficial reflexes were present. Plantar was flexor. Deep tendon reflexes were present, with knee being 3+. Sensory system was normal. Cerebellum, upper limb was normal. Lower limb we could not elicit. There was no bradykinesia, tremor, or painful rigidity. There was no spine tenderness. He could not perform straight leg raising test because of restriction of motion. There was no peripheral nerve thickening, but Tinel sign was present for the ulnar nerve at the elbow. So this is a video of his gait. So as we can see that he takes small short steps, and he has to hold the bed for support, and he's walking with the fear that he might fall down. Sir,
Yeah, thank you, Dr. Uma, for the case presentation. I'll carry forward from this point. Yeah, at this point, I would like to consider the previous comments which have been posted. Someone suggested stiff person syndrome. Yes, we considered stiff person syndrome as a possibility. And one of the audience opined that a mix of UMN, LMN could be ALS, like with Parkinsonism, GOM syndrome. But for Parkinsonism, it was predominant in the lower limbs and back, and though upper limbs have rigidity, the other symptoms of Parkinsonism like bradykinesia or tremor were not there. And for ALS, it's the upper limb wasting is confined to ulnar innervated muscles. Yes, and pain is definitely against MND. Significant pain is the main complaint. Ankylosing spondylitis, as suggested by one of the audience, is one of the possibilities that we considered. And corticospinal tract plus venous congestion in the cord leading to LMN, particularly if there is a CV junction anomaly leading to stagnant hypoxia leading to hand muscle weakness, that is one of the possibilities. But one significant pain in the lumbar region and lower limbs is unexplained. Manganese toxicity, again, that causes significant Parkinsonism with bradykinesia and tremor. So bradykinesia is not there in this patient. Upper limbs bradykinesia was not at all. And axial rigidity was definitely more than the appendicular. But at the time of his presentation, he was already 2.5 years into the illness. So the lower limb stiffness is almost as severe as that of the back stiffness. And here someone commented as Hirayama. Hirayama again, it's predominantly an LMN illness, and significant stiffness in the lower limbs is unexplained. Neuroletherism and conjo being stiff limbs, they can also present with stiff limbs, but he doesn't belong to an endemic area for neuroletherism, and he doesn't have that diet. And someone asked whether he had autonomic symptoms. No, he doesn't have any autonomic symptoms. And someone commented whether he had abdominal rigidity. The abdominal muscles were not board-like, but yes, they were stiff than normal. So at this point, I would carry forward the discussion. So to summarize, we have a 23-year-old male who has presented with insidious onset, gradually progressive, painful rigidity involving back for 2.5 years and bilateral lower limbs symmetrically for 2 years, leading to stiff-legged gait with possible bilateral compressive ulnar neuropathies at elbows without bowel, bladder, cognitive, cranial nerve, cerebellar, and other sensory symptoms with a negative family history. To consider the differential diagnosis, the same differential diagnosis remain, although the peripheral nerve hyperexcitability syndromes are unlikely because on examination, we couldn't find any fasciculations or myokymia. Also, myelopathy is less likely because the stiffness is predominantly rigidity rather than spasticity. Although minor weakness, because hip was 2/5, we think it is predominantly due to pain and rigidity rather than weakness. And it is not velocity dependent, and only knee is 3+, other reflexes are normal. And next, plantar was flexor. So we think myelopathy is not the predominant cause of his disability. So our provisional diagnosis is stiff person syndrome. He has been evaluated outside extensively for myelopathy, and routine investigations including hemogram, renal function tests, liver function tests, HbA1c, thyroid function tests, and vitamin B12 levels were all normal. MRI LS spine with whole spine screening was done, which showed loss of lordosis with mild degenerative changes without any compression. HLA-B27 was negative. The bone scan was done outside, which was normal. Anti-TPO antibodies were normal. NCS was showing bilateral ulnar neuropathy with CMAP and SNAP drops in the bilateral ulnar nerves, and prolongation of FIO latencies in peroneal and tibial nerves, suggesting possible alpha S1 radiculopathy. Lumbar puncture was done, which show the CSF showed nil cells. Protein was mildly elevated with 48.1 mg per deciliter. Sugar was normal. Oligoclonal bands were negative. PET CT showed no evidence of malignancy in the body. Anti-GAD antibody and serum paraneoplastic profile, including anti-amphicin antibody, were negative. We did surface EMG. Surface EMG, we used 8 channels, 2 channels on the right biceps, 2 channels on the right rectus abdominis, 2 channels on the right lumbar paraspinals, 2 channels on the left quadriceps. The goal of surface EMG, the purpose of surface EMG in stiff person syndrome is to demonstrate continuous motor unit activity at rest, which exacerbates with any cutaneous stimulus, usually given by median nerve or other cutaneous nerve stimulation by electric stimulation, and decrease in the motor unit activity with midazolam. So unfortunately, our machine did not have the facility of simultaneously stimulating a nerve while recording the surface electrodes. So I stimulated by bending the right knee, which was quite tight, and produced a painful stimulus for him, and observed the response in the left quadriceps. The monitor is showing the continuous motor unit activity at rest in the left quadriceps, which you can see now on bending the right knee. The motor unit activity in the left quadriceps has increased dramatically. And even after removal of the stimulus, the increased motor unit activity persisted for some time. After this, we gave 1 mg of midazolam, and the rigidity of the lower limb dramatically reduced. In this picture, you can see the right lower limb is fixed in that position even after the removal of stimulus. It is not coming back to the bed. Even after giving midazolam, the rigidity has reduced dramatically, and the pain has almost disappeared. So our final diagnosis is cryptogenic stiff person syndrome. We call it cryptogenic because we didn't find any evidence of antibody positivity, and also we didn't find any evidence of malignancy. So the stiff person syndrome can be, even though it is called cryptogenic, it is most probably caused by an unknown antibody or antibodies which we didn't test off. So we gave the patient pulse methylprednisolone 500 mg IV BD for 5 days, and we followed it up with oral prednisolone of 1 mg per kg body weight, and we gradually tapered it over 6 months. Recently, we stopped the steroids. He was initially started on clonazepam 0.5 mg per day, which we increased to 4 mg per day, and baclofen was added, which he is currently receiving 40 mg per day. IVIG was offered initially, but he was not affordable, so azathioprine was started as a steroid sparing agent after testing for TPMT mutation. The rigidity and pain decreased to a major extent. Now he is pain-free and having very minimal rigidity. Mobility has increased, and bending difficulty was still present, although to a lesser extent. He still has fear of falling, but this was initial video where the gait, this is before giving midazolam and before starting the treatment. We can see the patient is very anxious about walking, and he is fearful of falling, and he is walking with slow steps. The stride length is very less. It's as if a log of wood is walking. That's why it's called a wooden man gait or tin man gait. They usually have hyperlordosis also. And he has great difficulty in turning also. He couldn't turn by himself, so he was calling his mother to help. And he had great difficulty in sitting. And he almost fell down while sitting in this chair at that time. Someone has commented, is there any significance of hyperpigmentation? Dermatologist opined it as stasis related hyperpigmentation, and USG was done, which showed incompetent perforators. So probably it's related to that. And the ulcer is probably pressure sore, as he was bedridden for 3 months before presentation. And someone has asked whether there is any other systemic involvement. No, there was no other system involvement. Yes, as we can observe, he almost fell down while sitting. And this video is at 3 months of follow-up, where we can see that he's walking on his own and the stride length has greatly improved. Although turning is a little bit difficult for him at this point also. This is the sitting and bending videos at 3 months. So he was able to sit with much ease, and although bending, he was not able to do much. These videos were at 6 months. So as we can see, he still has some fear while sitting. He fears that he will fall down. This is a much lower level at which he is trying to sit. And the bending has improved compared to 3 months follow-up. He is able to bend much more now. The walking, the gait has remained almost same, mainly because he is anxious, and due to the same reason we started anxiolytics recently and got a psychiatry counseling for him. I'll be discussing in few slides regarding the clinical features and management of stiff person syndrome. So stiff person syndrome is a rare disorder characterized by progressive muscle stiffness, painful rigidity, and spasms involving the axial and proximal limb muscles. It was first described by Morse and Walkman in 1956, where they have described 14 patients with tightness of back, abdominal, and thigh muscles. They had progressive fluctuating rigidity and painful spasms, leading to a characteristic wooden man or tin man appearance with postural instability and falls. The main pathogenesis in stiff person syndrome is excitability in the spinal cord. The GABAergic interneurons are usually inhibitory, and they reciprocally inhibit the reflexes in the spinal cord. This reciprocal inhibition is defective in stiff person syndrome. The reciprocal inhibition prevents co-contraction of agonist and antagonist. For example, if you contract your biceps, the triceps has to relax. Reciprocal inhibition achieves this. If GABA is defective, either due to antibody-mediated or cell-mediated immunity and spinal interneuronitis, then GABA is defective and it cannot inhibit this reflex. So the agonist and antagonist both co-contract, and this will result in segmental hyperexcitability and in turn intersegmental hyperexcitability. So any stimulus can precipitate spasms. Auditory or cutaneous stimulus can also precipitate spasms in them, and the spasms are painful. Antibody profile in stiff person syndrome consists of both presynaptic and postsynaptic antigens. Presynaptic antigens include GAD and ampifysin. Postsynaptic antigens include GABA A receptor associated protein, geoffrin, and glycine receptors. The diagnostic criteria have been put forward by Dalakas et al. In 2009, but these diagnostic criteria are considered too stringent, and many of the classical stiff person syndrome patients also might not satisfy this criteria, particularly the GAD positivity criteria. So basically, they include stiffness of axial muscles, particularly the abdominal and thoracolumbar paraspinals, with superimposed painful spasms triggered by unexpected tactile or auditory stimuli. And they will have usually severe anxiety with their task-specific phobias, especially in anticipation of physically challenging tasks. And electromyographic evidence of continuous motor unit activity is required for the diagnosis. Absence of other neurological findings should be there. In our case, there is ulnar nerve neuropathy, which might not satisfy this criteria, and also we didn't have positive anti-GAD antibodies. But we did have response to midazolam, which is also considered by many as one of the diagnostic criteria, though it has not been put forward by Dalakas et al. To go into little detail about the clinical features, this table is taken from a study published from Mayo Clinic in 2012. They studied about 99 patients of stiff person syndrome. Among them, 79 were GAD positive and 20 were GAD negative. Among the GAD positive patients, all the patients have had lower back stiffness and spasms and lower extremity stiffness and spasms. This they call it as classic stiff person syndrome. Partial stiff person syndrome phenotypes do exist with involvement of only limbs with sparing of the trunk, or involvement of only trunk with sparing of the limbs, and some cases are reported with involvement of only the neck and upper limbs also. Other comorbid conditions might coexist with stiff person syndrome, which include cognitive disorders, myoclonus, epilepsy, Parkinsonism, myelopathy, peripheral neuropathy, depression. In our patient, peripheral neuropathy is there, but we think that it is probably due to compressive ulnar neuropathy. And he had a history of depression with psychosis. Other associations, systemic associations include adult type 1 diabetes mellitus, Graves' disease, pernicious anemia, and vitiligo, which are part of the autoimmune spectrum, and GAD-related cerebellar ataxia. Evaluation consists clinical evaluation, and one of the most important parts of evaluation for stiff person syndrome includes surface electromyography, which demonstrates continuous co-contraction of agonist and antagonist muscles with inability to relax and response to midazolam. Antibodies, if positive, render confidence to the diagnosis, and every patient should be evaluated neuropsychiatrically to diagnose anxiety and other neuropsychiatric conditions, because they frequently coexist. Treatment includes GABA A and GABA B agonists, modulators of GABA transmission, and immunosuppressive drugs. The only treatment which has been proven in an RCT is IVIG, which showed significant response. All other treatments are based on anecdotal evidence. And some patients do improve with only diazepam or benzodiazepines, whereas some patients require immunosuppressive drugs and respond dramatically to them. And some patients are refractory to some treatments. So it's a wide spectrum, and individually we have to see every patient. This slide is also taken from the Mayo Clinic study, which shows the outcomes of the patients over a 5-year follow-up. 25 patients had 5-year follow-up. Among them, we can observe one interesting thing. The initial MRS, if it is less than 4, those patients had good outcome in the final follow-up. Whereas if 4 or more MRS initially, those patients usually had static MRS or somehow worsened. And those who have 4 initial MRS of 4 or above, majority of them remain the same, but some do improve. For example, patient number 21 improved from 4 MRS to 0. Patient number 32 improved from 4 to 0. And also patient number 78 improved from 5 to 1. So, and this patient received only diazepam. And some patients received immunosuppressants like mycophenolate mofetil, azathioprine. Some patients received rituximab. To conclude, stiff person syndrome is a rare but potentially treatable cause that can spare the patient from significant morbidity and mortality. Surface EMG has an important role in the diagnosis. We can take some questions if there are any. So someone has asked, is there any role for B12 injections? I don't think B12 injections have any role in stiff person syndrome. And can they develop contractures? So yes, if any patient can develop contractures if mobility is not maintained and range of motion is not maintained.
And
yes,
I congratulate both Dr. Radhakrishnan and Uma for an excellent case. And in fact, and when Dr. Radhakrishnan came to Chennai, there's a lot of feedback from the teachers in AIIMS, and they told me he'll be an asset to any institution. And you have proved that today. I'm very happy to see a lot of learning points in this. I myself didn't know that the surface EMG which you have done is so invaluable in this stiff person. Thanks for a wonderful presentation and discussion of the case, Dr. Radhakrishnan.
Thank you, sir. Thank you very much.
On behalf of the Neurological Secrets course, I congratulate both of you. Thank you so much.
Thank you very much.
Good evening. I'll be presenting the case 2. I'm Dr. Shravya final year resident in from Sri Ramchandra Medical College. Chief complaints. Here we are presenting a 29-year-old married woman who was accountant by occupation, presented with chief complaints of generalized pain since 1.5 years and weakness of all 4 limbs since 1 year. Coming to the description of symptoms in detail, the patient developed pain initially involving lower and upper back regions 1.5 years back, which then slowly progressed to involve all 4 limbs, that is lower limbs more than upper limbs over the next 5 to 6 months. Pain was described as aching or soreness without any burning or squeezing character. The pain was constantly present and it was aggravated more by attempting to move the limbs. There was no radiation of the pain, no history of joint pain or swelling or early morning stiffness, no history of fatigue, malaise or other constitutional symptoms, no history of exercise intolerance, no history of cramps or contractures, not associated with high colored urine or cola urine, not associated with mood disturbances, and there was no preceding history of fever, weight loss or drug intake prior to the onset of pain. Coming to the description of weakness, after 6 months of development of pain, patient developed weakness in the form of difficulty in getting up from sitting position since 1 year, which was insidious in onset, gradually progressive to the present point where the patient was unable to get up from sitting position without support. This was followed by history of difficulty in gripping slippers since 8 months, leading to aware slippage of footwear, which was insidious in onset. However, the patient felt the weakness of the gripping of slippers weakness was relatively less when compared to getting up from squatting position. History of difficulty in lifting both arms above shoulder to reach overhead objects since 5 months was insidious in onset and gradually progressive. No history of difficulty in gripping of objects, buttoning or unbuttoning. History of difficulty in turning side to side in bed and getting up from bed unsupported since 2 months. This was the time at the presentation to the OPD. There is no history of difficulty in lifting the head off the pillow, drooping of eyelids or orthopnea. Weakness was not associated with thinning, flailness of limbs, twitching of muscles, stiffness of limbs, or involuntary spasms. No history of diurnal variation of weakness, fatigue, cramps, contractures, hypertrophy, or inability to release objects. This is the temporal course of the symptoms. Initially, March 2018, patient had pain onset. Following that, she had lower limb proximal weakness in the form of difficulty in getting up from squatting position in September 2018. Following that, she had lower limb distal weakness in Jan 2019. And she developed upper limb proximal weakness from April 2019. Following which she developed trunk weakness in July 2019 and then presented to our OPD in September 2019. Coming to the negative history, patient was able to feel hot and cold water equally on both sides of the body, was able to feel clothes equally on both sides of the body, no history of tingling, numbness or pinprick-like sensation, no history of cotton wool-like sensation, no history of any smell disturbances, recent onset of diminution of vision, defective perception of colors, no history of any drooping of eyelid, double vision, or loss of sensation over face or difficulty in chewing, no history of deviation of angle of mouth to one side or stasis of food on one side or drooling of saliva or difficulty in closing eyes, no history of loss of taste sensation, no history of hard of hearing or vertigo, no history of difficulty in swallowing or alteration of voice or nasal regurgitation, no history of difficulty in marshalling the food in the mouth using tongue, no history suggestive of altered higher mental functions, no history of swaying while walking or smearing of mouth while eating, no history of slowness of activities or involuntary movements, no history of postural giddiness, increased sweating, bladder or bowel disturbance, no history of drug intake, exposure to toxins, trauma, no history of weight loss, weight gain, heat and cold intolerance, skin rashes, no history of fever, altered sensorium or seizures. Past medical history. Patient is not a known case of epilepsy or thyroid disorder or diabetes or hypertension and previously was never hospitalized, and she consumes mixed diet, has normal bowel and bladder habits and normal sleep pattern. family history, she is born out of consanguineous marriage and is third by birth order, and no history of similar complaints in the family members. Here on, I would like to invite any comments.
Yes. Thank you, Shravya. I'll take it from here. Good evening to one and all present here. I see a few comments already, and I'll be addressing it in the approach. So after history, we approached the complaints with two important questions. Where is the lesion and what is the lesion? So with regards to pain and where it was arising from, this has already been discussed in the previous case, but I'll just run through it. Usually, if the pain is arising from a cutaneous area, we expect precise localization and a sharp pricking, stabbing or burning character. If it is a facial pain or periosteal pain, we expect precise localization to tender points. And if it's joint pain, we expect joint swelling, warmth, and the pain tends to be in proximity to the joints. And if it is a muscle pain, it tends to be, the patient tends to complain that he has a soreness or an achy quality, whereas it can be both generalized and localized. Radicular pain is shock-like radiating and has specific aggravating factors like cough and postural change. And with regards to central sensitization disorders like fibromyalgia, the pain is usually multi-site, is associated with fatigue, sleep disturbances, and psychiatric complaints also. So the pain in our patient seems to be arising from muscle probably, and we'll discuss with regards to what is causing the probable myalgia. So now approaching this muscle pain, the muscle pain can be, has to be first categorized as localized or generalized, because each of them have separate category of etiologies. So the causes of localized pain include strenuous exercise, trauma, pyomyositis, myofascial pain syndrome, muscle infarction, or compartment syndrome. The pain in our patient was generalized, and it has the following etiology. It can be infectious causes like bacterial, viral, which usually is acute in onset and has associated constitutional symptoms. It can be because of immune-mediated disorders, like I see in a few comments, like polymyalgia rheumatica, where the age is usually above 55 years and morning stiffness is prominent. Inflammatory myopathies, where there is associated weakness. Rheumatoid arthritis with joint changes. It can be SLE, where the patient usually has other systemic manifestations, or the vasculitis, where you expect to see palpable purpura or focal neurological deficits or any neuropathy related changes also. Then non-inflammatory pain syndromes can also cause diffuse myalgia like fibromyalgia and chronic fatigue syndrome. But as mentioned earlier, the patient also complains of fatigue, sleep disorders like unrefreshing sleep, and probably associated psychiatric disorders like mood disorders. The diffuse myalgia can be due to metabolic myopathy, where a patient also has other symptoms like exercise intolerance. It can be nutritional. It can be because of endocrine, wherein there is a characteristic set of symptoms to differentiate, like cold intolerance, weight gain, or history of hyperpigmentation, recurrent giddiness, hypoglycemias. And it can finally be due to drugs or toxin exposure or general psychiatric disorders. Now, let's put a pin on this symptom and let's discuss the second, analyze the second symptom before coming back to this. The second symptom of weakness, which the patient was aware enough to differentiate from pain-related restriction of movement, was symmetrical, proximal predominant with mild distal limb involvement, with no sensory, autonomic, or cranial nerve involvement. There was no spasticity. There was no involuntary spasms. The patient did not have any wasting, twitching, or flailness. But considering that the long duration of weakness and there was no spasticity and the proximal predominant weakness pattern, an element type of weakness was considered, and with the most probable structure being muscle, due to the proximal predominant weakness, absence of sensory symptoms, no diurnal variation, and presence of this pain, which we had previously localized to a probable muscle site. The other structure we considered was nerve bar radicle or neuropathy, considering that the weakness was both proximal and distal. But the presence of severe pain and the absence of sensory was unusual. So putting all this together with regards to what lesion was again, and considering that the probable structure involved was muscle, and putting together the pain for which we discussed DD, myopathies with myalgias were considered, including inflammatory myopathies in both due to connective tissue disorder and primary immune mediated myopathies, infectious myopathies, myositis, nutritional or endocrine myopathies, muscular dystrophies or myotonic dystrophies, which can also have some degree of pain, inherited and metabolic myopathies, and myopathies due to drugs and toxins. But in the absence of constitutional symptoms, no family history, the age of onset being 30 years, with a relatively rapid progression of symptoms, and no history of exposure to toxins or intake of drugs, we thought the most likely etiology could be either immune mediated or endocrine bar nutritional myopathies. We'll proceed with the examination. Any comments at this point?
Coming to the examination, patient was conscious oriented and pulse rate was 82 per minute regular. BP was 110 by 70 mm of Hg. Temperature, she was afebrile, and no cutaneous changes were observed like rashes, ecchymosis, hyperpigmentation, erythema, hair loss, or any nail changes. Higher mental function examination, MoCA was 30 by 30. Affect and mood was normal. Cranial nerve examination, all cranial nerves were normal. Coming to the motor system examination, pain was noted to be generalized or diffuse and over the muscle bulk, and no focal tender points were noted. No rashes or hyperpigmentation on the muscles. No swelling, warmth noted. Tenderness was present on the muscle bulk. No joint tenderness or mechanical limitation of movement was observed. Other motor system examination, bulk of both upper limb and lower limbs on both right and left side was normal. Tone was normal on both sides, both of upper limbs and lower limbs. No myotonia was seen. Proximal power was weaker when compared to distal power. In shoulder, the power was 2 by 5, and elbow it was 3 minus by 5, and wrist it was 4 plus by 5, and hand grip was good. Lower limbs, the same applies in lower limbs. The proximal power was low in the it was 2 by 5, and distal ankle, all the movements at the ankle were mildly weak. Superficial reflexes, abdominals were present, and plantars were bilateral flexor. Deep tendon reflexes, jaw jerk was absent, and all other deep tendon reflexes were brisk. Other modalities of examination, sensory, cerebellar, autonomic system, spine and cranium were normal. Coming to the summary, she's a 29-year-old female who presented with 1.5 year history of insidious onset, gradually progressive, generalized pain over the back and limbs, and 1 year history of insidious onset, gradually progressive, symmetrical, proximal predominant weakness of lower limbs, followed by upper limbs, with no wasting, spasticity or hypotonia or fasciculations, without higher mental function, cranial nerve, sensory, extrapyramidal and cerebellar symptoms, with negative family history. And examination confirmed the weakness with reflexes being exaggerated and flexor plantar. I would like to invite comments at this point.
Yes, sir. I see a few comments. Neck muscles were normal. She was able to lift her head off the pillow until the very end. And her gait, she had difficulty in standing without support, sir. And because of the pain and the weakness, she didn't mobilize much. Someone had to hold her to take a couple of steps. So she was predominantly bedbound. Okay, I'll proceed with I'll proceed with my further analysis. So after examination, we inferred 2 points additionally, which was that the reflexes were very brisk. which was more characteristic of some endocrine myopathies. And the pain was severe and significant, which was which made inflammatory myopathies less likely, though the connective tissue related myopathies can still have significant pain. So at this point, our primary etiological diagnosis was endocrine myopathies and nutritional myopathies. So proceeding to evaluation. So the patient came to us with these tests where the hemoglobin was normal. There was no evidence of infection. The renal and liver parameters are normal. Sugar test was normal. CRP, ANA, dsDNA, and CPK was normal. Her calcium, magnesium, vitamin D, TSH, and thyroid profile were all normal. But considering that we had a strong suspicion of endocrine myopathy, all her investigations were, a bone mineral profile was resent, which showed again a normal vitamin D, PTH, calcium, magnesium, but a phosphorus was low. This was the only clue we had from our initial set of investigations. Endocrine opinion was sought, and as advised, a 24-hour excretion of phosphorus was evaluated, which was very high. So we considered that something was pushing the phosphorus out, and we checked the levels of FGF23, which were also found to be very high. And following this, a presence of a phosphaturic tumor was suspected, and the patient was advised to do a 68 gallium Dotanox scan of the whole body. We proceeded with it. The Dotanox scan picked up a Dotanox avid sclerotic lesion in the, as you can a sclerotic lesion in the lateral aspect of the right humerus. This was a report which also additionally showed that patient had osteomalatic features noted in the axial and proximal appendicular skeletal. The patient had meanwhile been started on phosphorus supplements along with calcium, and she reported 25% improvement. So we considered orthopedic opinion, and who avulsed and curated the lesion, and samples were sent for HPE. So this was the histopathology, where it shows spindle-shaped cells enclosed by a bony trabeculae, which is positive for SAD2 and FL1, which are immunohistochemistries, which eventually proved that the tumor was a mesenchymal tumor, which is phosphaturic as well. So on follow-up post-procedure and during follow-up, the patient reported significant improvement of her pain and weakness, nearly 70%. And when we examined her, we found that her proximal power had improved to 4+ in upper limb, and in lower limb, it had improved to 4-. She was now able to sit up on her own and stand and take a few steps with support. So this was our evaluation and diagnosis for this case. Vitamin D level was, from the comments, was marginally low, but not very low as to explain her degree of severity of her symptoms. PTH level was normal. So the uniqueness of this case and the reason behind presenting it is that though metabolic or endocrine myopathies could be the initial differential for such a clinical picture, the focus is usually on vitamin D, parathyroid, or related concerns, like in this particular case, as they are more common. We would like to highlight that phosphorus disorder should also be considered as a part of differentials for such a clinical picture. The causative basis of this case arises from the elevated levels of FGF23. It is a protein or enzyme secreted by osteocytes in response to calcitriol dietary phosphorus load, whose primary function is to maintain the normal body phosphorus levels by increasing phosphorus excretion or decreasing absorption. So increased levels can lead to reduced phosphorus levels in the body. Apart from this, FGF23 interestingly also has other multisystemic manifestations like increased inflammation leading to vascular complications, fibrosis, LV hypertrophy, and immune dysregulation. So as to why reduced phosphorus causes muscle manifestation can be explained at two levels. At the cellular level, reduced phosphorus causes reduced ATP synthesis and reduced ATP synthetic flux subsequently, which leads to an impaired cell membrane structure, which translates macroscopically to a normal muscle size but with lower muscle density and lower muscle power. A note on phosphorus and neurology. It can cause various CNS manifestations depending on the level, where hypophosphatemia can cause your seizures, encephalopathy, and even CPM. Myopathies, hyperphosphatemia can cause seizures again with intracerebral calcification and manifestations of hypocalcemia, interestingly. So I just showed a couple of CTs, images showing calcification in hyperphosphatemia and CPM features in hypophosphatemia. Moving on. Treatment, with regards to treatment, oral is preferred generally to parenteral treatment, as a rapid phosphorus correction can lead to hypocalcemia, arrhythmias, and even AKI. So generally the dictum is if the levels are less than 1, we have to proceed with IV. If more than 1, then oral. And oral phosphorus has to be again initiated in small doses and titrated up very gradually, as it can cause diarrhea. In our case, tablet Adphos was initiated at 500 mg per day and slowly titrated to 1000 mg per day. This was an interesting case series or cohort of 18 patients published in Osteomalacia International with similar complaints who presented to the neurological OP. Almost all the patients presented with either pain or gait disturbances, and as you can see, a lot of them turned out to be having a tumor-induced etiology. And this picture can again be produced by either low calcium levels, low phosphorus levels, or even low vitamin D levels, as evidenced in this slide. Thank you.
Thank you. Thank you, Dr. Ritwik. Wonderful proposition of this FGF, fibroblast growth factor 23, which is incidentally, they have noticed that it is also inhibits the plasminogen activator inhibitor. So there are a lot of, in fact, in COVID myalgia, a lot of work is going on to relate this phosphaturic hormone on COVID myalgia, where essentially almost every patient has a severe muscle pain.
Yes.
And there is no direct evidence of COVID in any of the muscles, and even the lot of autopsies, they were always attributing to the inflammatory cytokines toxicity on the muscles and muscle necrosis. There are a couple of labs which are working on this phosphaturic hormone as one of the important cause for pain. And I saw in few of the, but anyhow, phosphorus as a neglected mineral and highlighting a wonderful case. My hearty congratulations to you and the presenter. And I don't know how do I pronounce her name? Shravya Inampudi.
Ainampudi, sir.
Inampudi. Shravya Inampudi, both wonderful case. Thanks to both of you.
Thank
And
you.
over to Professor Sundar for concluding remarks.
And thanks, sir. Thanks for the lively discussion. Why aches and breaks? Why these two cases? Because this is to emphasize to the DMPGs or the physicians that any patient who comes with muscle weakness, confirming to myopathy, the differential diagnosis can be narrowed by the presence of the associated symptoms. Here, there are two cases emphasized. One is muscle disease with aches, another is muscle disease with breaks. Aches means painful myalgias, and breaks are to note the muscle spasms. So if we come across a patient with the myopathy, the DD can be narrowed if the patient associated symptoms of aches or breaks are present. So the learning point to be emphasized in the first case is, so patient, you have seen the video, and the patient comes with the stiff muscles, not only muscle weakness, stiff muscles. If you rule out rigidity, Parkinson's symptoms by the absence of hypokinesia, other extrapiramidal symptoms, and if you rule out spasticity by the absence of typical spastic tone, the DD is very narrow. Any patient, if you rule out any rigidity, spasticity, then the stiff person DDs are only three. One is central causes, stiff person syndrome, peripheral nerve hyperexcitability, which is Marwan's Isaacs, and muscle is myotonia. These three groups of stiff person syndrome, peripheral nerve hyperexcitability syndrome, and myotonia, the main point of emphasis is do EMG. If you have myokemia or neuromyotonia, the DD goes for peripheral nerve hyperexcitability syndrome like Marwan's Isaacs or cramp fasciculation syndrome. If you have myotonia, waxing, waning, dye-bomber sound, it goes for myotonia type diseases. And if you see this patient surface EMG showing co-contraction, agonist, antagonist, and repeated muscle contraction, then it goes for stiff person syndrome. So this is what the main learning point. Any person who comes with the stiff limbs, if you rule out spasticity, rigidity, think of these three important groups. One is central causes stiff person, peripheral hyperexcitability, and muscle diseases. And coming to the second case, the main point is, as the presenter has told, the DDs of myopathy with myalgias are many, but any patient who has myopathy with brisk reflexes, kindly think of endocrine myopathy and evaluate for that. This patient presented to us with myopathy, and we found out the cause and we removed it, and he has improved. So this second case emphasis is learning point. Main learning point is, if a patient with myopathy with brisk reflexes, think of endocrine myopathy. These are the two learning points which I want to emphasize. And once again, I thank the course coordinators for giving us this opportunity. And thank you, sir.
Thank you so much, Dr. Sundar. Sir, Professor Sudhir, sir, your comments?
Yeah. So I think both cases are brilliantly diagnosed and presented also very nicely. And there was a great learning point in each of them. And I must congratulate the Institute for the students at this level. I think most of the things are clear, and there are nothing much to add to this. But one must remember regarding the stiff person syndrome, one of the partial stiff person syndrome affecting the right lower limb, and it was a lot of difficulty for us to, come to the diagnosis. Ultimately, we could. And so the different presentations, like in this case also vesting and other things, so we have to keep in mind that there are outliers also in SPS syndrome. It could be partial syndrome, it could be generalized syndrome, it could be paraneoplastic, or it could be encephalomyelitis with myoclonus and rigidity and all that. So the spectrum we have to remember. And this phosphorus case is absolutely amazing. I didn't know about this entity in such a way, and the PET was wonderful in giving the diagnosis. So I think sometimes investigations rationally step by step should be encouraged, and many times it is very rewarding. I mean, just to add a line, how sometimes, detailed investigation helps. I had a chance to see Muniraj, who was 65 years, and he had some typical complaint. He said, Dr. Shah, whenever I touch my tip of left index finger, I get local current and sensations, abnormal sensations. I've shown to many people and I don't know what it is. I also, in examination, did not find anything. I gave some prescription here, there. He came back after a week, he called me, just see. To cut the matter short, ultimately, I had got his MRI of the finger, index finger, done with a lot of, good resolution. And it turned out to be small ganglion. And we removed it and it's fine. So sometimes these fancy investigations used judiciously do have a role in neurological management. And this Munishi was suffering for last, say, 5-6 years. He got relief. So I then would like to once again thank all of you, particularly the panelists, and of course the delegates for their continuous support, their interest, and I thank my friend Dr. Lakshmi and Arun Chadda, the head of Global Cell team, for the enormous support in this program. We hope that all of you will shower your blessings and also your affection and participation in the coming year of 2022. All the way, Happy New Year to all of you. And as COVID is around again, marching with the third or so-called fourth wave, be very careful, take care of yourselves, whatever best you can, and do not take unnecessary, brave steps to, face unnecessary difficulties. God bless us all. Thank you very much. Dr. Lakshmi, we may
Yes, sir.
close.
Yes, sir. I wish all the participants a healthy, happy New Year and Shankranti greetings, advanced Shankranti greetings to all of you. And as Sir said, take care, be safe. Let us be your aim to come out without any complications in the third wave. That is my prayers to all of you. And now from South, we move on to Delhi in the last Friday of this month, to RML Ram Manohar Logia. Professor K.S. Anand will be taking the next meeting in the last week of this month. Thank you so much. I hand over to Mr. Arun Chadda for his final conclusion.
Thank you very much, sir. First of all, Happy New Year to all the participants. Today it's really a great day that we are at the end of 18th session of Secret of Neurology web series, which is the longest web series with such a successful web series. And I, Arun Chadda, Associate Vice President, on behalf of Intas Pharmaceutical, would like to propose a hearty vote of thanks to all the honorable delegates who blessed us with their presence in the last 18 months. It's audience like you that make the presentation awesome. Today, first of all, I would like to congratulate our Honorable Course Director, Dr. Sudhir Shah sir, for receiving the Royal College of Physicians Fellowship. Heartiest congratulations to you, sir, from entire Intas.
Thank you.
And I would
Thank you so much.
And I would like to thank our Honorable Course Director, Dr. Sudhir Shah and Dr. Lakshmi Narasimhan sir, for designing such a fantastic web series on neurology, which will be very helpful to all the DM and DNB students. And I would like to thank our young neurologists, Dr. Uma and Dr. Shravya, for presenting the excellent and unique case. Further to this, I would like to thank Dr. Radhakrishnan and Dr. Ritvik for presenting the case investigation and discussion. And thanks to Dr. Sundar, Associate Professor, Shri Ramchandra Institute of Higher Education and Research in Chennai, for providing important learnings for the proceeding of these unique cases and expert comments also. The entire presentation will be extremely helpful and informative to all the participants. Once again, thank you for your gracious presence. And it's been clear being with all of you today and again in the subsequent sessions also. Thank you for your patience. And I wish all of you a very good night in this month. And we are meeting again in this month on 28th of Jan 2022 with yet another most awaited next session of Secret of Neurology. Till then, stay safe and take care. Thank you. Thank you to all of you. Thank you, sir.
Thank you, sir.
Thank you all.
Thank you.
Thank you, everyone. Thank you, sir.
Thank you. Thank you, Dr. Radhakrishnan, sir.
Bye. Thank you.
Thank you, sir. Thank you very much. Sport team.
Rohit, we can end.